Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by a lady I met several years ago in association with the issue of catheter-related bloodstream infections and was struck by Dr. Silvia Munoz-Price's depth and breadth of knowledge, combined, of course, with a charming personality and a lovely humility. Silvia was born in Peru and obtained her medical degree at the Universidad Peruana Cayetano Heredia in Lima. My apologies for my atrocious pronunciation. Her residency in internal medicine at the Good Samaritan Hospital in Baltimore, Maryland, Infectious Diseases Fellowship at Tufts New England Medical Center in Boston, Massachusetts, and her PhD in Epidemiology at the University of Miami Miller School of Medicine in Florida. She's previously held senior positions at various places, including the Jackson Health System located in Miami and the Medical College of Wisconsin, serving as professor of medicine. She's been hugely active in research and publishing and the management of the institutions she's worked at. She's won multiple awards, served as a reviewer and on editorial boards, is a sought-after speaker and collaborator, and currently serves as the treasurer for the Secretary of Hospital Epidemiologists of America. Silvia is double board certified in infectious diseases and internal medicine and has recently decided to go into private practice in Destin, Florida. She's had a wonderful and prolific career in academic medicine and can now focus just on patient care. On the rare occasions that Silvia has some spare time, she tells me that she enjoys oil painting on canvas, sculpting, cycling, running, traveling, enjoying fine food, and watching movies with her family. And I'm sure we're going to have a rich palette to decorate the canvas of our conversation. So welcome to the podcast, Dr. Silvia Munoz-Price. It's definitely a pleasure to be able to speak to you again and to have you here with us.
Oh, thank you very much for that introduction, Jonathan, and thank you for inviting me. It's a pleasure to be here.
Well, it would be nice if we're in the same place. I believe you're in Florida at the moment. London is quite bright, but a little bit chillier than there, I'm sure.
So, yeah, I mean, sunny Miami.
Yeah, absolutely, as it always is. So you've got immense and diverse experience across several institutions at a time where hospital consolidations have become the order of the day, and health systems in the United States have been gobbling up local and even distant primary care practices and other practices to integrate care pathways. That was going on when I was still living and working in the United States, but I know the pace of it has accelerated. Can you talk to us about how these consolidations impact quality, which is almost certainly the most important metric of all?
Yeah, absolutely. Well, consolidation for hospital systems is actually a very interesting phenomenon. It will seem that every time hospitals feel under stress, they consolidate, they merge, they acquire one another. It's kind of like a knee-jerk reaction. And that has been accelerating during the last couple of decades. And what is concerning is that these merger and acquisitions, even though the hospitals argue that it increases efficiencies, it increases lowers costs, etc., it actually ends up producing or causing higher costs and lower quality, which is very interesting. And it is associated with a lower competition within markets. And
is that what drives the increase in costs, the reduction of competition?
In part. I mean, if you think about it, hospitals want to increase their margins, right? They want to increase their profits. And what makes them stronger against insurance companies is consolidation, because when they have greater market share, which actually can be measured, but when they have greater market share, they have more power to ask for higher reimbursement. And I can elaborate on that, Jonathan. It's actually very interesting. There's a way to measure that within a market. Let's say that you have 10 hospital systems within a given market, okay? And let's say that the percentage of admissions in each of these hospitals is 10% out of the 100%. You can come up with an index, it's called HHI, that goes from 0 to 10,000. But let's say in this example, each of these 10 hospital systems have 10% of the market. That HHI in this example will be 1,000 because it's the sum of the squares of that percentage of the market share. However, let's go to the other extreme. Let's say that one hospital system has 100% of the market. That's the extreme, right? But in this case, the HHI will be 10,000. A monopoly, right? That health system can do whatever it wants. It can charge whatever it wants to the insurance companies because there are no competition. Yeah, exactly. And the insurance companies, they have to pay that. And there's something in the middle. And the cutoff is usually 3,500. So HHIs of 3,500 or higher are considered monopolies or low competition, and less than 1,500 is considered highly competitive. And unfortunately, in the United States, we have a trend in which most markets now are they have monopolies or have low competition because of these mergers and acquisitions. And the reason why this is important to me is that when you have low competition, when you have monopolies, you're going to have lower quality and higher prices, which is unacceptable, right?
Yeah, very much so. I mean, the impact of competition, you know, in a system like the British National Health Service, folks in America think that money doesn't flow. Money does flow here, and competition is important. What tends to happen in America, of course, is if you've got 5 hospitals in a region and one gets a newfangled piece of equipment, you guarantee that the other 4 hospitals will get it because they want to compete, whether it makes economic sense or not, because there's the knock-on effects. People who go to somewhere to have their interventional cardiology procedure might also end up getting their hernia repaired there and all the other bits and bobs doing. So it's a fascinating space. So I want to move on a little bit. You've served in various roles as various hospitals around the country, as I mentioned, and you've been involved in looking at safety events and how to reduce safety events, and have done extremely well with that. What sort of lessons have you learned from those sort of activities around the country? Different places, different examples.
Yeah. So it's actually very scary when you think about it. All the things that can go wrong in healthcare systems, and sometimes they do go wrong, right? And events that shouldn't happen, but safety officers, such as the role that I had as Chief Quality and Safety Officer, I think have the responsibility of ensuring that several processes are in place so to prevent these mistakes from happening. I think a fundamental role of health systems, and especially the departments of safety, quality and safety, is to ensure that we're not going to harm patients while patients are admitted or are under the care of a healthcare system. That is unacceptable to cause harm, especially when harm is preventable. And so how can we, health systems, standardize processes so to minimize these errors from happening?
So there are the federal guidelines, aren't there? The so-called never events, the Medicare never events, things like falls or ventilator-associated pneumonia or decubitus ulcers or catheter-related blood, any of these sort of things that people say, well, that shouldn't happen. It's preventable. Of course, that was handed down from on high in the United States. There are similar things over here. How does one stay ahead of the game and spot, trends within a hospital, especially as we're constantly introducing new diagnostic and therapeutic modalities? How do we as physicians, instead of relying on one person to sort of like a big brother or big sister, keeping an eye on us, how do we all participate in those sort of quality metrics?
Oh my goodness, that's a complex question. That doesn't have a straight
That's
answer.
my job. I get to ask the complex questions, and my clever guests get to answer.
Let me use one of your examples, which is falls. Something that happened during the COVID pandemic in the United States is that safety events in general in the hospitals across the United States, and not just safety events, but hospital-acquired infections like you described, increased markedly. There was a breakdown of those processes because people went into kind of like a survival mode, right? And many things that were instituted to prevent those errors from happening were broken down. So let me give you an example, and false is actually an interesting one. In order for falls not to happen, there are many things that need to occur, but let me give you an actual example, an actual intervention, a very granular one, and it's toileting the patient. So imagine this, think about this 80-year-old or 85-year-old lady who was admitted to the hospital with change in mental status, and all of a sudden that patient wants to go to the bathroom and gets out of bed, tries to go to the bathroom, falls, breaks her skull. It's actually fairly common. It's not uncommon. Let's just say it's not uncommon or unheard of. So in order to prevent these situations, what many hospitals do, is they toilet patients. So instead of waiting for a patient to want to go to the bathroom, they have a cycle or a schedule in which patients are taken to the bathroom, regardless of the fact that they may or may not want to go to the bathroom, so that they do their necessities, and there's not that need in between these scheduled events of having to go to the bathroom and accompany. But what happened during the COVID pandemic or subsequently during the 2021, 2022 is that labor costs went up markedly, right? Nursing wages went up tremendously, part of it because of the travel agencies, right? Travel nurses. And some people were scared about working in a hospital. So that combination of those two things decreased, at least in the hospital where I was working at, the number of nurse aides. And the nurse aides are the people that take patients to the toilet. You don't have a staff that takes patients to the toilet. Well, what do you think is going to happen? Right?
Why not?
Exactly. And then how do you correct this problem, especially when visitation is limiting the family members that could help taking patients to the toilet? So a combination of issues happened during the COVID-19 pandemic that increases this type of events from happening.
Yeah. So I fly airplanes, Silvia, as an avocation, and there's a system within the the aviation sector, that pilots can report how something that went wrong with the system that might have included them doing something wrong, like misinterpreting an air traffic control instruction or doing the wrong thing in the air or on the ground. If they take responsibility, own up, and report it, right? Number one, the whole system can benefit. Oh my goodness, the instruction could be made more clear so that people wouldn't misinterpret it. And secondly, it's a no blame system. Okay, you're human, you made a mistake, let's make the system better. I don't know that we do a very good job. I think we're better in medicine than we used to be, but I think we're far from perfect and could do a better job having a no fault system of, identifying where things are going wrong. And sometimes, anyone within the system can help improve the system.
And I actually love your example, but that assumes that the system, the fundamentals of the system, the airplanes and people who fix the airplanes, et cetera, works. But what happened during COVID-19 and, all those years, and we're living with repercussions of that, is that the system broke down. So if you were a pilot and you were telling, the system, listen, there's a problem here and there's a higher risk that the plane may fall. But they come back to you and tell you, okay, but we understand, but we cannot fix that plane with what we have. So
yeah,
tough life, right?
Yeah, it's a good point. Yeah, I know, pushing rocks uphill, herding cats, and all that. You mentioned the COVID-19 pandemic, and during that time in Wisconsin, you served on the COVID-19 preparedness response and vaccine allocation teams. Do you think you've mentioned about things going wrong? Do you think we've learned the lessons of that time and are well prepared for what invariably comes next? What did we do well and what did we not do well?
So before I answer that question, let me share with you that it was very interesting to see what happened with the behavior of the population during that time. When there was a scarcity, meaning when there was no vaccine and we were preparing to allocate vaccine, everybody wanted the vaccine. Everybody was arguing why their particular group, pregnant people, older people, healthcare workers, why they were the ones that should have the vaccine first, right? Scarcity, no vaccine. Then the scarcity disappeared and you start entering a phase of mandates. And then you see the other side of the coin in which people are telling you, we don't want the vaccine. And you shouldn't be telling me that I should get vaccinated, which was a very interesting phenomenon from my standpoint in Wisconsin.
If I can just jump in and say to you that there's a friend of mine, Dov Barron, I will credit him because it wasn't me that came up with this, it was him. He talks about the emotional source code that people have. And the American emotional source code is freedom and liberty and self-determination. And the mistake was telling Americans to get vaccinated. If instead would have said, if you want to be free to barbecue and go to the baseball game, you might want to consider getting vaccinated. Now, British people tend to be a little bit, if you want to have fun on a London street, stop on a corner and just look up and stand there looking at your watch. Within 10 minutes, someone will come up and say, is this where, are you queuing here? You're lining up here? And they'll stand behind you. And within half an hour, there'll be 30 people standing in line because we're a very orderly civilization. So I don't know if you agree with that or not, but it was a strange phenomenon. But anyway, tell us about preparedness. What did we do well and not do well?
So there were some... I think there were some very good lessons learned during the COVID-19 pandemic. It was great that we had a vaccine developed in 300 plus days, right? That was amazing. And CEPI, which is an international organization, that works in the preparedness for these pandemics. Now, based on that experience, is trying to even shorten the duration from the detection of an outbreak to the delivery of vaccines from 300 days to 100 days. And actually, they're trialing this as we speak in Rwanda with the Marlborough outbreak going on there. So, great lesson learned during COVID-19. The other thing that we started doing as a country is to use new sources for surveillance. An example of that is wastewater surveillance. What does that mean? So, water that comes out of sanitation water, right? That comes out of the, I'm blanking on the name.
Yeah, like sewage, sewage, wastewater.
Sewage water is being collected in different cities in the United States nowadays, and tested for a variety of viruses, so that when the levels go up, and they go up before cases are usually detected, but when levels go up, that is a sentinel event that is telling you there's something that is going to happen within this population. And usually that has a geographical difference, right? It's heterogeneous in the United States. So what may be happening in Colorado is not necessarily what's happening in Florida. So it is great for early detection of outbreaks. And that is actually for something that Rwanda is using now for the Marlborough outbreak as well. What did we did not do well? Well, unfortunately, as I'm a hospital epidemiologist, and I think our epidemiologists in general, and including the CDC and scientists in general, during the COVID-19, had an erosion of the trust of the population, which was unfortunate. And I think a lot of it had to do with the changes in recommendations over time, the inability that we had to predict. And that is something that I lived on myself, right? People in my hospital will ask me, in Wisconsin, what do you think is going to happen? Well, we had never lived through something like this. How could I tell you? And every time I try to predict something, usually that did not happen, or something else happened. And you can see how that erodes the trust that people have in my specialty and in scientists in general, which was painful to see.
You know what? As a follow-on question observation, I saw a video that you posted, and during that time, and there were comments, and one was, it seems like the people that have taken the shot are the ones that are spreading the virus, or no thanks, and no thank you, I don't trust the vaccine, it's experimental, and we don't know what the future will happen. People are dying to, please stop telling us what we have, it's all about control, that is communism. How do we, people call it vaccine hesitancy, which I always think is, it's trying to put lipstick on a pig. It's trying to make something gloss over what it really is. I think we've done a poor job communicating stuff. I mean, there are people who are completely oblivious to the fact that RNA research has been ongoing for many, many years. And they don't understand how vaccines are made, and that we're making new vaccines every year for flu, right? For influenza. So how can we do a better job with that? And what's the influence of social media?
Oh my God. I think social media has been very deleterious for science in general, right? Misinformation. I think that way too recover from it is through relationships between patients and their physicians, the basics. And that is something that I experienced during the last couple of months when I was providing care in a clinic in Richmond. If the patients really believe that you want to help them, that their well-being is the most important thing for you, if they sense that, they are going to do what you recommend. So it is, do I trust this physician more than I trust the misinformation that I'm seeing on social media, right? And I think that we can tilt that balance with those patient-physician relationships by using trust, right? By strengthening the trust.
I think we also have to accept the fact that social media is here to stay. The internet is an echo chamber. The algorithm feeds you what it thinks you want to see. And once you've demonstrated, I've played around always through a VPN and taking on a persona just to see what the search engines provide me with. And it is scary because it doesn't present you with a balanced overview. It doesn't present you with a search of everything. It presents you with what it thinks you want to see. And that is scary. Well, you've mentioned Richmond. Let's change tack slightly. There's a lot of discussion nowadays about health equity, health equality. I left America a few years ago after many years there. How does American healthcare reconcile? It's a perfect storm. You've got an expanding population size, ever wider wealth gaps in America, more and more complex and expensive medicine and decreasing budgets, and a lack of competition because of consolidation. It's a perfect storm. Is US healthcare rearranging the deck chairs on the Titanic and heading for an iceberg?
Well,
I asked you a question, Silvia. You see, it's your fault. You're a smart lady. When we first met, you impressed the hell out of me. So I'm going to ask you good questions.
Well, you put it really depressing, but let me just share what I saw during the last few months when I was working at this free clinic. It's a free clinic that takes care of a population that does not have any insurance, and it does not have Medicaid. And the reason why they don't have Medicaid is because they are undocumented immigrants, which are becoming more and more common in the US. And putting politics aside and putting the why and that, should they be here or not, they're here, right?
Absolutely.
So again, apolitical. This is a population that needs primary care interventions. It's primarily Hispanic, and Hispanics, including my family, by the way, have a high predisposition of diabetes. And what I saw is that most of these patients had diabetes. They didn't know that they had diabetes. Some of them had very high glycemias with hemoglobin A1Cs in that range of 11, 12, without even knowing about it, right? And the problem here is that if we don't take care of this population now, if we don't prevent the evolution of these chronic diseases, they are going to come to the emergency rooms of our neighborhoods, right? They are going to be admitted with much more expensive conditions, like heart attacks, like limb ischemias, like blindness. So I think we need to put politics aside. This population is here. We need to do something to control their chronic diseases, because otherwise it's going to be much more expensive. And something that we use in epidemiology is to say that one ounce of prevention is worth a pound of cure. And that is true at any level of prevention. And here too, it will be so much cheaper to take care of them now than to wait for them to be crushing in the hospital.
So it's kind of like, there's the act where there's a magician and they're doing a show and they pick on some of the others and they say, now we haven't prepared this. You don't, we don't have some agreement that you'll say something specific, but you said a few things that are a perfect segue. You're a supremely well-qualified lady. You've got executive healthcare leadership certificates, Lean Six Sigma certification. You're currently earning your master's in healthcare management at a little place called Johns Hopkins. So like similar, very smart, committed professionals that I've spoken to, I've got a few questions. And you did say, an ounce of prevention, a pound of cure. Pound is also the unit of currency in my country. So I've got a sort of a linked question for you. Number one, why in heaven's name will American healthcare not learn from what the British do well? And conversely, why will the British not learn what America does well? That's number one. Number two, I think you're saying basically, wouldn't it be nice if politics would butt out of medicine and we could actually just do the business of looking after the people who are here? And yes, I used to live in San Diego and I saw a lot of folks coming over from Mexico, most of them illegally. And you're thinking, if I was in the same situation, I would do exactly the same thing. They're trying to feed their families. They were hardworking people. And wouldn't it be nice if we could actually provide healthcare for them? And the third element is, should more doctors be involved in actually managing healthcare rather than people with MBAs and no heart? So who should be running healthcare? Why can't we learn global lessons? And how the hell do we get politics out of medicine? The floor is yours. What did I do to deserve this? She's thinking.
You touching several points as usual. Very interesting topic. Why is it that the healthcare system in the United States is so expensive? It is not a simple answer. Why is it that we're not like the UK or other European countries, right? Again, that's a very complex answer. But why is it that the healthcare system in the US is so expensive? And I'm going to tie your third question right here. It has, somebody that has written on this topic, and I'm a fan of, is a healthcare economist who is actually, I think he's German, but he lived in the United States for most of his life. And unfortunately passed a few years ago. But he wrote several papers. One of them was titled, "It's the Price is Stupid," which I love. I love that provocative title. And later on, before he passed, wrote a book about it that is called Priced Out. His name is Uwe Reinhardt, again, healthcare economist. And he, I think he synthesized, he elaborates on this topic, of course, but the synthesis of this, of why the American healthcare system is so expensive, he makes 4 points. One is that we can afford it, right? Because if we were talking about an African country, for example, even if prices were that high, they wouldn't be able to afford paying for it. Yes. But the US can afford it. That's one. Two is the prices of each test, each procedure in the United States are much more expensive than in Europe. It's and any other place in the world. It is a misconception to think that the U.S. population gets more tests, more healthcare products than elsewhere. That is not true. Actually, European citizens get more tests, they get more procedures. What is different is the cost per procedure. That's what's different, and that's the reason of the title of one of his articles, which is It's that cost, it's the price is stupid.
Yeah.
And the other one is the increase in administrative force, non-bedside jobs in healthcare, in the U.S. healthcare, administrators. And that is tying it with your question. Non-physicians get very nice salaries, right? You look at presidents of hospitals that have MBAs and fairly limited knowledge of healthcare. Some of them get over $1 million in annual salaries, which is being paid by who? By the patients, right?
You're right.
And you could argue, is that the right model?
I think we need more people like you running it. Actually, I will share with you. I'm beginning to get so irritated by this because I have similar discussions with people over here about the frailties of this system, and there are problems here. Absolutely, there are problems, and I have the nugget of an idea that wouldn't it be great to get together people from both sides of the duck pond and from other countries who in leadership positions and try and come up with a white paper. This is what a healthcare, if we were starting with a blank sheet of paper, this is how it should work. This is what it should do, right? And I got a funny feeling that if we actually do the right thing for patients and put patients at the center, right, and not a hospital president and not a doctor and not an insurance company, but the patient, will end up with a system that actually works better and costs less money, I think.
Well, that's a good idea. And Singapore, actually, it was a good experiment of that hypothesis, right? Because Singapore had Uge Reinhardt and his wife, among others, come and consult and help them design their healthcare system, their current healthcare system, which is not cheap, but is much better. Basically, what they did is they took all the good elements of all the healthcare systems across the world and created theirs.
Yeah. But the other thing is that healthcare economists and healthcare systems and everyone else who touches the dollar, they're looking at only a fragment of the patient's journey from cradle to grave. And you mentioned a diabetic. If we take someone with diabetes and we provide them with tight glycemic control and dietetic help and exercise physiology, all the things that we could do to change the course of their disease, might we not actually over the course of their life dramatically reduce costs, not just financial costs, but human costs, emotional costs, system costs? Anyway.
Yeah, you're actually touching again on prevention versus cure, right? And the problem that I'm going to say it again that we have in the United States is that we don't focus on prevention, we focus on cure. And we are very good at providing very highly specialized, expensive care for patients. But we are not as good in providing preventative care for the population. You can hypothesize why, and reimbursements being one. I mean, why is it that primary care physicians are becoming less and less frequent and more difficult to find, right? It's because their specialty is not as well reimbursed as, say, a surgeon. So medical students prefer to do surgery, ophthalmology, dermatology, everything that will increase their salaries and provide them with a better quality of life than primary care or pediatrics or even infectious diseases, which is considered um, not as well reimbursed, especially.
Yeah. Understood. So I mentioned in my introduction that you're the current treasurer and former counselor of the Society of Hospital Epidemiology of America, SHEA. How do you see the role of SHEA evolving in the current healthcare landscape, especially with changing migration patterns and the emergence of diseases like monkeypox? And I'm sure there's going to be more zoonoses to follow COVID-19 and monkeypox and Lord knows what else. And you mentioned Marburg earlier, and I can vaguely remember hearing about Marburg, but that's about the limit of my knowledge.
Well, infectious diseases is such a dynamic specialty, and hospital epidemiology, which is the profession that is the basis for SHEA, the Society for Healthcare Epidemiologists of America. We aim to prevent transmission of infections, especially within healthcare, but also in communities. And it is just very interesting what's happening nowadays with that changing behavior patterns of the population, number one, the change in the environment and the climate, and how this may not only be impacting the organisms, but also the immune response of people. So we just need to be as nimble as these organisms on figure out how to best prevent these infections. And you mentioned H5N1. This is a very interesting outbreak happening with an avian virus. It started in the 1990s, and now it has newest strains have appeared and have infected not just birds but also cattle, right? And the concern is that these strains may mutate to be more transmissible among humans. At this point, they are minimally transmissible between humans because of how they attach in different receptors within our upper respiratory tract. But if they become more efficient or better at attaching into our upper airways, then we'll be dealing with another pandemic.
Yeah. I was in Australia about a year or so ago, a couple of years ago, and up in Queensland, where I did an elective many years ago, and the landscape has dramatically changed. And where there was rainforest coming down to the waterfront, there's now homes and buildings, which means the habitat has been damaged. And at dusk, I watched massive, massive flocks of, I think they were flying foxes and bats and Lord knows what else, flying around the harbor with airborne guano, bombarding your cocktails. And I'm thinking, my God, what viruses are we being exposed to, and how long until the next one? So that with that sort of like Hollywood disaster movie setting, let's as we move towards the final scenes of this palette that we're painting. If you were to be advising young men, young women who are going into medicine and thinking about going into infectious diseases, epidemiology, what would you be saying to encourage a young woman, for instance, to take on your profession?
Such an exciting field, very dynamic. You don't only deal with the host, humans, but also deal with organisms that mutate, that change, never boring, right? So if you're curious and you like investigations, decide to go into epidemiology or infectious diseases. Yeah, that's the career for you.
I have to tell you, Silvia, I'm sick to death of hearing about, and I'm sure there are people who do suffer from burnout and so on and PTSD. Everyone seems to have something nowadays. It is such a joy to talk to someone who has your positive attitude. It's uplifting. So my final question for you is, you come across a magic genie as you're wandering along the beach in Florida, your toe kicks a spot, you pick it up, you rub it, out pops a genie and offers you 3 wishes for your area of healthcare. What would those wishes be?
Again, focusing on prevention and less on cure. If we were just to focus on prevention and what does the population, putting aside the patients, right? Because patient means disease, but the population, how can we prevent diseases before they start? Exercise, diet, etc. I think we will be so much better off as a society, as a country, maybe with less money to begin with, because all these third parties wouldn't be able to make money, right? But
Yeah.
but it will be so much better for us. So I only have one wish: prevention.
Well, that's very gracious of you and very generous. I'm afraid that's all we've got time for today. So I'd like to thank you, Dr. Silvia Munoz-Price, for being with us today, and frankly, for all you've done for patients and the science and art of medicine, and all I know that you will do. And wishing you the very best at your new practice in Florida. It's a real pleasure chatting with you.
Oh, it was my pleasure, Jonathan. So I thank you so much for inviting me. This was a lovely conversation. Thank you.
It was delightful. I wish we could have done it in person. So, folks, if you've enjoyed today's episode, and I presume if you're still listening to me drone on, then you have, please consider subscribing on Spotify or Apple Podcasts. Write a review, tell your friends. It does help. And check out the archives. There's over 200 fantastic episodes with great guests. And by subscribing, you'll never miss an episode. And finally, please join us next week for another fantastic episode. Until then, I'm Dr. Jonathan Sackia. Thanks for listening to the MJ podcast. Please, everyone, stay safe, stay well, stay curious. Bye for now.